Okay. It's okay to not be a host, but if you can you give me privileges to control my screen? Okay. Hello, everyone. If you can hear me, we're going to get started in just a few minutes. Thank you for all being here. Okay, hopefully everybody can see me all right here. Welcome. Thank you all for being here. We're going to get started in just a second. All right. Hello and welcome to the first ever NewportCare seminar series. I'm Dr. Ian Dworkin, and it's my honor and pleasure to be here to welcome you all to the talk tonight. about spine anatomy and common causes of neck and back pain. While we may feel very isolated from our healthcare providers because of COVID, it's my hope to stay engaged with our community and to make sure we're all available for our patients, whether it's online or in person. So one of the ways to do this is through the lecture series tonight. So again, thank you all for being here. I hope this talk's really informative, and I hope we'll have plenty of time afterwards to answer any questions that you might have. But if this talk doesn't cover everything you hoped it would, don't worry, be on the lookout for future talks that will be going into more topics that will build off of what we talk about tonight. So the goals of the talk will be to learn a little bit about the spine and why it's so important to us. We're going to learn about some common causes of neck and back pain and their symptoms. We're going to have some time for questions afterwards, and then also have some contact information available in case anybody wants to schedule a personal evaluation if interested. First, a little bit about the practice. Though many of you know us here at NewportCare, we have 3 main offices, one in Newport Beach, one in Long Beach, and one in Riverside. But what some of you may not know is that our Newport Beach office recently changed locations to up the street from our old office into a brand new building that we have all to ourselves. We now offer a full spectrum of care, all the way from physical therapy, chiropractor, and acupuncture, through orthopedic spine and joint surgery, with everything in between, including podiatry, hand surgery, family medicine, men's health, as well as interventional pain management, which is my specialty. We'll have more contact information at the end of the talk, but if you're interested in making an appointment with us or just want to learn more about the practice, please feel free to give us a call or visit us on our website. You can also email us at info@newportcare.org below. And you can even follow us on NewportCare on our Instagram to check in and see our shenanigans that happen on a day-to-day basis. So also before I get started, I wanted to just mention a few things we're doing here at NewportCare to ensure that everybody's being cared for in the safest way possible. So we have face masks available for all patients and providers throughout the visit. We have increased space in our waiting room to allow for proper social distancing. We're also offering the ability to complete forms online prior to visits, so you don't have to spend any extra time in the office that's not needed. And that's also emailed to all of our new patients prior to their visit. We're also offering drive-up COVID testing at our Newport Beach office with a very quick turnaround. And we're developing our urgent care services at several of our locations. Finally, we're also prioritizing telehealth appointments when appropriate and preferred. Just a little bit about myself. Again, I'm Ian Dworkin. I was born and raised in Philadelphia, Pennsylvania, where I completed my undergraduate degree and then completed my medical doctorate at Jefferson Medical College. I then moved out to Los Angeles, where I completed my residency in physical medicine and rehabilitation, and then my fellowship in pain medicine, both at UCLA, and I'm now double board certified in both of those fields. My personal aim is to provide comprehensive evidence-based care with compassion in a multidisciplinary and individualized approach to everybody's unique symptoms. I typically provide care for various painful musculoskeletal conditions as well as spinal conditions using non-surgical and minimally invasive interventional pain procedures. So why is it so important for us to be talking about neck and back pain? Well, neck and back pain are among the most common causes for seeking medical care. Back in 2009, one study estimated that $200 billion was spent annually on the management of back pain alone. We can only imagine what that number has ballooned up to nowadays. Back and neck pain are also among the most common reasons for lost work hours and productivity. And beyond just the discomfort of the pain, it can lead to depression, fear avoidance behavior, and disability, all affecting our prognostic outcomes and our quality of life. So to best identify some of the causes of neck and back pain, it's also helpful for us to understand more of a foundation of the spinal anatomy, so we know it's being disrupted by these various causes. One of the jobs of the spine is to support and protect the structure of the body, the nervous system, and the organs. The spine allows for movement through the interaction with various muscles, limbs, and joints. And the vertebral column is composed of 33 vertebrae, skull, ribs, and sternum. We have 7 vertebrae in the neck. We have 12 vertebrae in the thoracic spine. We have 5 vertebrae in the lumbar spine, 5 in the buttocks or the sacral region, and 4 that comprise the coccyx or the tailbone area. We can also see here on the right side, the normal spinal alignment and the normal curvature that exists throughout the spine. Our spines are not meant to be straight, and so this curvature allows for proper movement and weight distribution. So first we'll discuss the neck or the cervical spine, and what's unique about the anatomy in the neck is that the vertebrae are a lot smaller, and this allows for better range of motion. Obviously, we need to be looking all around ourselves in our day-to-day activities, when we're walking, when we're driving, when we're interacting with the world around us. So it's really good that the vertebrae in this area allow for that. The vertebrae in the cervical spine also serve an important function for protecting the blood vessels that go to the neck and the brain, as well as the spinal cord, and has a normal curvature called lordosis, which we'll look at in a moment. Here on the left, we can see some normal ranges of motion in the cervical spine. We have some flexion here and an extension, side-to-side rotation, and lateral bending. Here we see an artistic rendition of the cervical spine. On the right, we can see what the vertebrae look like from above, and we can see the big vertebral foramen right here where the spinal cord runs. We also see the transverse foramen right here and here where the blood vessels run up to the brain. And then we can also see on the left here from the side or lateral view, the same structures. We can see the vertebral bodies right here that are separated by the intervertebral discs. In the center runs the spinal cord, and behind that are the spinous processes throughout this area, corresponding to the spinous processes in this view. And those are the protrusions that you can feel in the center of the neck. Here is a normal cervical spine x-ray to compare to that artistic rendition. Right here, we see a very nice normal curvature or lordosis of the cervical spine. We can see a nice alignment of the vertebrae here, or the bones. And although this is an x-ray, we can't see the intervertebral discs, but we can infer that they are right here between the bones. Here we can see an MRI, which allows us to see more than just the bones of the neck. We can use the MRIs to see musculature, nerves, and the intervertebral discs in a lot more detail. The image on the left is a view from the lateral or side view. And on the right, we're seeing the same part of the neck, but in what's called the axial view, from where we're looking up at the patient while the patient looks up in this direction. So it's really important for us to view the MRIs in multiple planes so that we can get a more complete understanding of the pathology and the associated relationships with the anatomy, essentially putting 2-dimensional images into a 3-dimensional understanding. So next we're going to talk about the thoracic spine. The thoracic spine is known for its stability, which is really important because obviously all our organs lie inside of the rib cage, and we have the spinal cord that runs through the thoracic spinal canal. Special characteristics of this area include attachment sites for the ribs. Because the thoracic spine is so stable, injuries to this area tend to be a little bit less common than in the neck and the low back. However, the drawback is that because of this stability, we lack a little bit more range of motion in the thoracic spine. We can see here on the left some typical range of motion exercises demonstrating the range of motion in the thoracic spine. Again, flexion and extension, and here we see some lateral rotation. This is a picture of the thoracic spine. Note the normal curvature of the spine in this area is called kyphosis, so it's a bending forward. We can also, again, see the close relationship with the spinal cord running right down in the middle. And here we can compare this to an actual normal x-ray of the thoracic spine right here. All these numbers correspond to the different vertebrae. Here on the left of that, we see an AP image, which is basically looking straight through the thoracic spine. Here we can see what a normal MRI of the thoracic spine looks like. We can't see the ribs in this view, but we can see again that important relationship between the vertebrae here, these square boxes that are lighter gray, and the elliptical discs that sit in between them, with the spinal cord running down right behind them. So finally, we're going to speak a little bit about the lumbar spine, or the low back. And what's unique about the vertebrae here is that they allow for all kinds of special attachments to the various muscle layers that are responsible for supporting the musculature of the body. Again, this is really important because the low back essentially is responsible for supporting the entire body above it. This has its disadvantages, though, because an injury to the low back can result in significant functional disability. It's also important to note that the spinal cord ends in the upper lumbar spine. It ends around the area of L1-2. And below that, we are talking not about the spinal cord, but spinal nerve roots that then descend and form bigger nerves that innervate the muscles of the leg. Here we can see a nice artistic rendition of the lumbar vertebrae. We can see above what the spinal canal and the lumbar spine looks like, just beyond the vertebral body of the lumbar spine, which the disc sits on top of. We can then see that in the lateral view, that nice relationship between the vertebral bodies and the blue discs that sit in between them. We can also see here behind that the neuroforamen, or the windows of the spine, where the nerve roots come out in the direction that my mouse is going, where they will run down and form bigger nerves, which will innervate the various muscles of the limbs. Posteriorly, we can see the facet joints back here, and we're going to talk about that later because that can frequently be a cause of neck and back pain. Here is a normal lumbar spine x-ray just for comparison. Again, we see nice alignment of the vertebral bodies, and we can see the nice neuroforamen windows that allow, again, for those nerves to run down. Here's an example of what a lumbar spine MRI looks like in different views. So we can see, again, the vertebral bodies right here, the nice big light gray squares, and the disc, the elliptical discs that sit in between them. Behind them is where the nerve roots run down, and then this is the back of the spine, the skin and the muscles of the back. Here on the axial view, we see those same structures, this being the disc, the nerves, the facet joints, and then the muscles of the spine in that view. The spine is comprised of many other components other than just bones, though, and a very important aspect of the spine is the intervertebral discs. They can actually account for a very significant portion of the spine. Up to a third of the length of the spine is composed of these discs. And the discs allow for flexibility without having to sacrifice strength in the spine. And it does so by providing a shock absorption, preventing the bones from grinding together. And we can see that relationship here as these bones are separated by the shock absorption properties of the disc right there. However, as we'll soon see, it can be a significant site of pathology. But we'll get into that in a few minutes. We also have a series of different muscle layers that comprise the spinal column. We have three major groups of muscles in the spine. We have a superficial, intermediate, and deep groups. And those all allow for various different primary motions of the back. So the flexion, extension, rotations that we spoke about earlier are all aided with these muscles. They also assist with respiration. Here's a little bit of a bigger image of that same demonstration of the muscles. We see the deep muscles here right in the center that are all attached to the vertebrae and the bones of the spinal column. Then we see the intermediate levels of muscles that are a little bit thinner but span the entire length of the spine. And then we see the superficial, bigger muscles that are a little bit more posterior and farther away from the spinal column itself. So that completes some basic spinal anatomy, and I hope that gives us a little bit of a foundational understanding before we dive into some of the conditions that cause pain in these areas. There's a lot of different ways that we can organize pathology of the spine, but I thought we would go based primarily on the site of injury that can occur. Now, this This list is by no means all inclusive, but I hope that we can at least highlight some of the most common causes of spinal pain that I see at NewportCare. Also keep in mind that this talk is not meant to provide any specific diagnosis for anybody, and that a proper diagnosis really requires an in-depth history, physical exam, and imaging. So if you do have particular concerns that come up during this discussion, please schedule an appointment. We can really discuss in more personal detail your unique symptoms. So first, we're going to begin with some injuries of the muscles and ligaments of the spine, which can be a very common source of pain. We're going to be talking about lumbosacral and cervical strains or injuries to the muscle, or sprains or injury to the ligaments. These groups together can comprise of the most common causes of spinal pain, and in the neck, it's commonly referred to as whiplash. Pathology comes from the muscle and tendon fibers that are abnormally stretched or even torn with excessive movements, including twisting, bending, and lifting. And here we can see an example of this type of injury. Notice that this x-ray shows an extremely straight cervical spine in this x-ray, as opposed to that normal curvature that we had seen earlier. And that's because the muscles and the tendons and the ligaments that all attach to the bones of the cervical spine are stretched and injured, causing secondary spasm, which can straighten the spine in this region. Symptoms of sprains and strains are typically axial in nature, which means that they just stay in the neck and back. They don't typically go to the limbs. We don't typically see any sensory changes in the arms and legs, and we don't typically see any weakness of any muscles. We also, in pure sprains and strains, don't see any major findings on the MRI. And symptoms can typically heal within a few weeks with the proper treatment. So the next thing that we'll be talking about is sacroiliac joint and ligament pain. The SI joint is located at the junction between the ilium, the bone right here, and the sacrum right here. So we're talking a little bit about this area. And there are also multiple ligaments that attach in this area, which can become inflamed and very painful. It's a very common but undiagnosed cause of back pain. So one study found that 15 to 30% of chronic low back pain occurs at this area. And it can either be a primary cause of pain, or it can actually be secondary to pain elsewhere, causing us to move because of the pain in abnormal ways and develop pain in this region. Pain from SI joint and ligaments are largely low back and can typically be very tender above the buttocks region in the dimples that many people have at that location. And as opposed to sprains and strains, pain in the SI region may actually radiate and travel down into the thighs. However, it doesn't typically go below the knees. A diagnosis of SI joint ligament pain is typically made clinically, but sometimes you can see arthritis or inflammation in the joint. And this is an x-ray that shows the SI joint right here and here, specifically right there. And we just see very little space in that joint, which indicates arthritis at the SI joint. One commonly misunderstood diagnosis is what many people call sciatica. So often people, when they say they have sciatica, it means they have pain or symptoms radiating down their leg. However, true sciatica actually refers to injury of the sciatic nerve, which is a major nerve that runs down the leg. And the most common place that nerve can get injured outside of the spine is actually in the piriformis, which is a muscle that we have in our butt region. So in many people, the sciatic nerve actually travels out of the spine and goes right through the piriformis. And so because of that, when this muscle gets really tight, it can squeeze on the nerve, and then all the nerve signals down the leg will be radiating pain, numbness, and tingling. Symptoms from piriformis syndrome can typically happen with strengthening or repetitive exercises like riding a bike, weightlifting, or long distance running, or even prolonged sitting. So there's a lot of different things that can cause pain here. Symptoms of sciatica may include buttocks pain with numbness and tingling down into the leg and the foot. Imaging can often be normal with piriformis syndrome. And here we have an image here that shows the relationship between the nerve and the muscles below it. So the next group of pathology that we'll be discussing is pathology coming from the intervertebral disc that we spoke a little bit about earlier. So the first thing we'll talk about, and one of the most common causes of neck and back pain that I see, is caused by disc herniations. So a disc herniation is when the outside of the disc is damaged, enabling the inside of the disc to push out of place. And this can cause an inflammatory response or compress some of the nerves in this area, resulting in significant pain and debility. It's very common, about 5 to 20 cases have been seen per 1,000 adults. So in a huge population, that's a very common issue to come across. Symptoms may include burning or stinging and can cause radiation of symptoms down the arm and the leg if there's compression of the nerves. And there can also be a lot of numbness and tingling as well. Pain may be worse with sitting or bending forward, and severe pathology may cause weakness or in the arm or in the leg. Here we see an illustration of what a disc herniation looks like. Normally on the bottom, we see the relationship where the disc is right here with the nerves running behind it. However, when it herniates, like we see right here, the contents of the disc push backwards into where the nerves run, right there, and can either, again, directly push on this nerve or cause inflammation, which can irritate that nerve, creating the symptoms down the arm or the leg. There are several different causes of a herniated disc. There's very important genetic factor to those who are predisposed to herniated discs, but also degenerative disc disease is a very common cause of herniated discs, and axial overloading, which is what I mentioned briefly earlier. When we're sitting or bending forward, we're putting a lot of extra stress on those discs, which predispose them to herniating. In the neck, the most common areas of this herniation are at C5-6 and C6-7, and in the back, the most common are at L4-5 and L5-S1. Here's a pie chart that demonstrates one study's findings of the most common causes of disc herniation resulting in radiculopathy or radiating symptoms down the arm and the leg. And though most people recall an inciting injury, it's actually interesting that the authors found that almost half of the cases right here, there was no identifiable cause of the herniated discs. However, out of the most common singular causes of pain, the authors found that falls, motor vehicle accidents, and lifting injuries resulted in pain from the herniated discs. But there were a lot of other causes, including general medical conditions, sports injuries, and pregnancy as well. Here we are going to look at some MRIs of what herniated discs look like in the neck. So we see the brain and the spinal cord coming down. Again, the vertebral bodies with the discs in between. And right here, we see a really large disc herniation there and there, pushing out into the areas where the nerves run. So you can imagine this could cause a lot of discomfort. We're now looking at a zoomed in view of a similar cervical spine MRI. The yellow arrow here on the left shows the disc herniation in the lateral view, and that corresponds with the herniation in the axial view, where we see this disc pushing on this white nerve here, and that can cause a lot of pain, numbness and tingling that goes down the arm and into the hands. Here we see what some of the herniated discs in the lumbar spine might look like. In the lateral view, we see a big disc herniation right here, and a little bit one right there. And this corresponds again on the axial view with the herniating disc occurring right here. The image on the right here is this is actually a progression of disc herniation in the lumbar spine. On the right, we see what the early herniation looked like with the bulge right here corresponding with the bulge right here. However, the patient came back several months later and had significantly worse pain. So another MRI was taken and we see a much larger disc herniation right there corresponding with the herniation right here, demonstrating how important it is to make sure we treat these discs before this kind of thing can develop and progress. So the next type of disc pathology we'll talk about is degenerative disc disease. Degenerative disc disease is degeneration of the intervertebral disc, which results in the bones of the spine getting closer together. Now, it is a normal process of aging that happens to everybody, and it typically starts in the second decade of life, where it's often asymptomatic. However, pain can develop depending on the extent of the degeneration and its location. It's therefore a very major contributor to neck and back pain because it predisposes the disc to the herniations we just spoke about. As with normal aging, the integrity of the disc will weaken over time because the supporting structure is called proteoglycans and the water content decreases. So those discs are less firm. They don't provide as much shock absorption as they did when they were younger. Additionally, degeneration of the spine is actually connected with damage of nearby structures such as ligaments, muscles, and joints, which can predispose us to further injury. Causes traditionally have thought to be smoking, occupational hazards, and injuries such as falls and accidents, but now we're also seeing the extremely important role that genetics play in this process. Symptoms can really range on a huge spectrum. They can be anywhere from asymptomatic when people are younger and there's less degeneration, to the development of symptoms that are consistent with disc herniation, spinal stenosis, and other causes of neck and back pain that we'll be talking about in a little bit. So here we see an image depicting the various stages of degenerative disc disease. On top, we see what looks like a normal disc with a normal disc height. The second disc here shows the beginning of the degenerative process with some lines going through it and a little bit of loss of disc height here. And then as we look down on the third and fourth disc, we see further development of bulging of that disc and the herniation of the disc as the bones start to get closer together with the associated progression in herniation. Finally, at the bottom, we can see a disc that demonstrates such significant degeneration that the bones are touching each other, and that can cause a lot of inflammation and pain and arthritis. And that's demonstrated by this image here. We can see the loss of the blue appearing disc in a normal spine into a degenerative spine here. And that's because, again, we've lost that shock absorption effect that the discs have. So then the bones start to rub against each other and they lose that smooth appearance that they typically have. And this is called osteoarthritis. These x-rays show a similar process occurring in both the neck and the low back, demonstrated by the arrows that we see here. We can see in both pictures that there's narrowing of disc space at these areas. And because of that, we're seeing osteoarthritis causing inflammation and abnormal bone growth called osteophytes, which can all be very uncomfortable and common causes of pain in these areas. Here we see a really interesting image of an MRI, which compares what a normal disc looks like. So we see a normal disc here. It's very elliptical. It's got nice disc height, to one that is starting the degenerative process right below. You can see it's a little bit darker in appearance because we're starting to see the bones push against each other and a little bit of protrusion here. And then further below, we see even more progression of the disc degeneration so that it's now herniated and bulging into the area where the nerves are. Here's a similar process that's happening in an MRI of the cervical spine. We can see here what normal discs look like in the upper cervical and the thoracic region. But then right here, we just see a smushed appearance of these discs. These bones are pushing against each other. There's very little space for these discs to be. And so they push backwards into the area where the nerves are. So I'm sure reviewing all this pathology brings up a lot of questions regarding prevention and treatment that I'll be largely discussing in my next talk, but I'm happy to address any questions you might have at the end of the talk today. Just stay tuned. We will be discussing in a lot more detail the treatments for these causes of neck and back pain. So finally, we're going to be discussing our last group of causes of neck and back pain, which focuses on the bones of the spine and how they can contribute to pain in the neck and the back. So first, we're going to talk about spinal stenosis, which is a condition in which the nerves are compressed due to narrowing of the spine. And this can occur actually in several different areas, and so has several different types of symptoms. It can occur right here in the vertebral foramen we looked at before, where the spinal cord sits. It can also happen at the lateral recess, where the spinal nerves are exiting, or it can happen at the foraminal region, where we have the nerve roots coming out. And so the symptoms will depend on where that stenosis is occurring. So causes of spinal stenosis can be congenital, or people can be born with spinal stenosis for various reasons, but the majority of the ones that we see in NewportCare are acquired. So they come from a trauma, such as a fall or an accident or a sports-related injury, or they can develop from degenerative disc disease, which we just spoke about. And we see on the right here, which demonstrates the stenosis or narrowing of the spinal canal due to progression of this disc herniation in the neck. Here we see what stenosis of the foramen can look like in a lateral and axial view. So we see again a disc bulge here, which corresponds to the disc bulging right here into where that foramen is. So those nerves that we looked at earlier that exit the foramen and go down and innervate the muscles are being compressed at this location. So symptoms really, again, depend on the location. Central stenosis, we often see symptoms that are bad with prolonged standing, walking, and bending backwards. And so it's actually one of the pathognomonic signs of this is called the shopping cart sign. And what that means is that people who have central canal stenosis and who are walking upright a lot or bending backwards a lot, that's where their spinal column is compressing the spinal cord and some of the nerves in that region, and that causes a lot of pain. So what they do when they're walking around a lot, especially in the supermarket getting groceries, is they'll get a cart and they'll bend forward. And by doing so, they're relieving some of the pressure on those nerves and lessening their symptoms. So that's something that we often ask our patients when we're concerned for central stenosis causing these symptoms. Foraminal or lateral stenosis symptoms that occur at these regions are often associated with the compressed nerves at these areas. So it's very similar to when a disc herniation is compressing that same nerve, but instead of the disc being the primary cause, here with spinal stenosis, we're talking about narrowing of the bones. And it's also really important to note that we're always on the lookout for red flag symptoms with spinal stenosis, which can include weakness or issues controlling the bowel or bladder, because this may indicate that spinal stenosis has become severe, resulting in myelopathy or damage to the spinal cord. So if any of these symptoms are ever concerning to you, please call us immediately after hours, during hours. We want to know about these symptoms, and you may need to go to the emergency room as soon as possible if they do develop, just because of the severity of the stenosis. So here again, just a couple more images comparing what a normal lumbar spine looks like here. See a nice open space for those nerves to run compared to a stenotic, spinal stenotic lumbar spine, where these bones here are just really pushing into the area where the nerves are running down. And here again, we see very severe spinal stenosis in the cervical spine, which can again cause a lot of pain, discomfort, arms, legs, can even result in some of those red flag symptoms that we discussed. So now we're going to talk about one final cause of neck and back pain, facet arthropathy, or arthritis of the facet joints that we had mentioned a little bit earlier that are located back here in the posterior spine. Facet arthropathy is the arthritis really disables the function of the facet joint. So our range of motion that we typically get from this joint is impaired. It is a very highly prevalent cause of chronic low back pain. Studies have shown 15 up to 41% of those with chronic low back pain might have facet arthropathy as the cause. So specific causes of facet arthropathy include degeneration of the joint from arthritis, but injuries can really exacerbate or speed up that process, including falls or motor vehicle accidents. So symptoms for facet arthropathy, just like muscle sprains and strains, are axial in nature. So again, those are non-radiating pains. Pain may be worse in the mornings or after periods of inactivity, and are especially worse with extension or moving the neck or low back backwards, because that really puts a little extra stress on the joint. Here we see an X-ray of a cervical spine with severe facet arthropathy. The facets are typically located back here, and typically we see a little bit of space between the facets, but here we virtually see no space in between them at all, with a lot of fuzziness of the bone indicating very severe advanced arthritis of the facet joints. Here we can see in the MRI of the lumbar spine a comparison between a normal looking facet joint right here compared to a joint that's undergoing facet arthropathy. So we can just see how much more swollen and inflamed these facet joints are. There's a lot of extra bone growth here, which adds to the size of these joints. And that's how we know, based on the imaging and correlating with the physical exam, that pain may be coming from these facet joints. So just a quick recap here, we reviewed tonight some clinically important features of spinal anatomy in the neck, thoracic, and lumbar spine. We discussed some common causes of neck and back pain. And if you missed something or you want to share it with somebody else, don't worry, we are recording this right now, and we hope to have a link up on our website soon. We'll also be emailing that out to everybody who signed up tonight. So now we're going to open up this discussion to any questions that you might have. Again, I'm happy to discuss anything related to this talk or any questions you might have about neck and back pain, but just keep in mind that for specific recommendations, I'd love to meet all of you face-to-face or over a telemedicine appointment so we can really further discuss your unique symptoms. So again, thank you all so much for attending tonight. I hope I can meet you all soon and talk about how we can help you. So thank you. Just give us 1 second here as we try to get some Q&As up. Some people did actually email us ahead of time, so thank you for that. So I'll try to address those first before we talk a little bit about some of the questions you guys typed in for us. So one question I had was about intrathecal pain pumps as a last option for permanent nerve damage pain. So intrathecal pumps, for those of you who don't know, is where we place a very small catheter into the thecal space of the spine. So the areas where the nerves run. And then we typically it's connected, that catheter is connected externally to a pump, a large device which holds the medication. And then the medication slowly delivers that medication directly into the cerebral spinal fluid of the spine to give people relief. So in general, intrathecal pumps are one of the last resorts for really chronic severe pain. For permanent damage, not sure what else has been tried first, but my goal is always to try everything, more conservative treatments first before we have to result in intrathecal pumps. They can be very effective at treating chronic severe pain that hasn't responded to anything else. So in that sense, it can be very effective, but yes, it is typically reserved as one of the last options for permanent nerve damage if everything else has not provided relief. So that's a great question. The next question I have here is, what's the best way to manage pain and discomfort after 5 back surgeries? Wow. So that's a lot of surgeries. And since I'm not a surgeon, I always try my best to utilize any other treatments that I can to prevent additional surgeries from happening. And we're going to get into a lot more about that in some of our future talks. But in short, I think I would, depending on your symptoms, sometimes interventional procedures such as certain types of injections, epidural injections can be helpful, radiofrequency ablations targeting some of the nerves in these different areas. And then after spine surgery, sometimes when the anatomies change, one of the types of treatments we do a lot here at NewportCare and that I'm especially interested in is something called spinal cord stimulation. And that's a really exciting treatment because it actually allows for us to trial the treatment before we have to commit to a permanent placement of the spinal cord stimulator. So great question. Look out for more discussion about this in some of our future talks coming up. Let's see, okay. So those are some of the questions that were emailed earlier. Thank you again for that. What's the best position to sleep while having a displaced disc around C5 to C7? So that's kind of a tough question to answer in general, because it would be best probably to look at the MRI to see exactly where that disc is herniating or being displaced, and also to know a little bit more about what kind of symptoms you're having. So I would say if the disc is being displaced in one direction, sleeping on that particular side might put a little extra pressure on that disc. And so you may notice some extra symptoms down the arm when you're sleeping on that side. So have to try to find perhaps sleeping on the other side or directly on your back might be a better solution. I find that often when patients say they sleep on their stomach, they're forcing their neck into extra extension, and that can actually exacerbate some of the symptoms because of secondary inflammation in that area. So one thing I would recommend is really coming in so we can look actually where that disc is herniating. And sometimes what I often recommend is a special orthopedic pillow that we can provide that really helps to protect the neck and to help keep people in a more comfortable position while they're sleeping, as opposed to most pillows, which may be a little too firm or a little too soft for people that have displaced discs. So one of the other questions that someone submitted is, can looking down at phones or tablets over a long period of time cause problems in the neck and the back? So really interesting question, great question, very relevant. Obviously today, everybody's got their heads down on the computer or on the phone. So the answer is definitely yes, it can definitely exacerbate neck and back pain, especially in the neck. So what was kind of interesting a couple of years ago, there was a study that came out where radiologists were actually seeing development of new bone growth in the neck because of people who had neck pain and were describing long periods of time with their neck in flexion looking at their phone. So they, kind of, they call it in layman's terms, phone neck. So yes, being on your phone or tablet for long periods of time can absolutely exacerbate the tension of the muscles in the neck. We looked at one of those x-rays earlier in the talk where the neck was very straight, and that was because of the injury and the chronic sprain and strains to the muscles and ligaments of the neck, causing the neck to be really straight. Because when we have our neck in one position too long, it can cause a lot of spasm and a lot of tension of that neck, and that can really cause a lot of debility and pain. So what I typically recommend when people are at their computers a lot for work is that you look, ask if those who you work with have any ergonomic modifications that can be made. And what that means is that someone can actually come in and evaluate the place you're sitting. They can evaluate the chair you're using, the desk you're using, the height of your computer and your mouse. And making some small changes to even the height of the screen can be really helpful for people that are developing neck pain from just being at the computer too long. So in general, you want to make sure that the screen is, your eye level is about the middle to lower third of the screen. And that allows for a little bit more of a normal posture of the neck, as opposed to if the screen's a little too low, we start to see ourselves get like this, and then we get a lot of secondary muscle spasm and pain from that. And then just in the low back, the phone in particular probably won't exacerbate the low back in particular, but just prolonged sitting and bending forward will do that, because as we saw when we talked about disc pathology, sitting puts a lot of extra stress on the discs, and then bending forward adds even more loading to those discs, and that can predispose it to herniation. So got another question about typical treatment for facet arthropathy. So this is great. This is going to lead us into some of the stuff we'll be talking about in the future seminars. But for facet arthropathy, there are a couple treatments. In general, we always try to start with some of the most conservative treatments first. So physical therapy, focusing on getting good range of motion back with strengthening and stretching exercises. And we have really great therapists here at NewportCare to help people with that. And then we gradually progress to a home exercise program. So sometimes that can be really helpful in itself. Sometimes medications such as anti-inflammatories or topical medications can assist with some of the pain too while we're pushing through therapy. And when some of those more conservative treatments haven't helped with the facet arthropathy, there are a couple interventional pain procedures that we employ to help with pain in this area. One of those can be injecting the facet joint itself with medication, which typically includes steroid medication, the goal being to just decrease a lot of the inflammation in that joint from the arthritis. However, another procedure that I typically do for facet arthropathy is called a medial branch block. And what that is where I put medication to numb the nerves up that innervate the facet joint. So instead of just injecting into the joint, we block the nerves that innervate the joint, which are very small sensory nerves. And that can oftentimes help people pretty significantly with the pain. That block, though, is typically only temporary. And if people get really good relief from it, they then will qualify for another procedure, which can provide much longer lasting relief, 6 to 12 months relief. Some data has even shown up to 24 months of relief, where we do what's called a radiofrequency ablation. So it's very similar to the block. The needles go in the exact same location, but instead of just injecting anesthetic medication, we will also be burning those nerves away. And that may sound a little bit scary, but we are just focusing on the sensory nerves of that joint. So we're nowhere near the motor nerves that innervate the muscles, and we're not affecting any of the other sensations of the body that you may feel. And to enhance safety, we do it under the use of an X-ray machine, and we also do what's called testing of the needles before we do the burn. So we'll give some stimulation through the needles so that you just feel the symptoms in the back and the neck, and that allows us to know that we are right by those nerves that innervate those facet joints, and then we can safely do the burn. So those are some of the questions that we've had here. I hope that was really helpful and provided some good answers for you guys. Again, if you have some questions that weren't answered tonight, or you have some concerns about some symptoms you're having, please reach out to us. I'd love to meet you all and talk to you more about how I can help with your pain in the neck and the back. And please stay tuned. We're gonna hopefully make a whole series of these lectures and bring in some other providers at NewportCare so that you can get a really full multidisciplinary opinions from all different physicians in our group. Again, thank you so much again for being here, and looking forward to hearing from you all very soon. So thank you so much.